Good afternoon, and welcome to the Cardiovascular Institute Clinical Conference. This conference is part of a program of translational research to clinical practice done with the Cardiovascular Institute and the Department of Surgery, the Department of Medicine, the Department of Neurosurgery, and the Department of Radiology. Last week we had basic sciences, and this week we have clinical sciences. And we alternate the presentations by different the services involved. You know, this time is the Department of Radiology that has worked together with the vascular surgery and interventional nephrology and cardiology to bring up the endovascular robotics. You know, we are very pleased to have with us Dr. John Bismuth, Assistant Professor of Surgery at the Houston Methodist Hospital, and to talk to that about us. And we are very pleased to have among us Dr. Robert Barish that honors us with his presence. So you're welcome to ask many questions, and I do not know if Dr. Bismuth would like to ask the medical students some questions about basic anatomy, not in robotics.
That's always good.
Okay, well, so...
I won't ask you about robotics, but maybe it's an anatomy, huh?
Okay, so we are very interested and looking forward to your talk.
Thank you very much. So I want to thank everybody for coming out to listen to this. It's a little bit probably for medical students maybe interesting as far as the technology, but not something you'll probably encounter during your days in medical school, although maybe the system is on its way here. I've been involved in this robotics venture for about 6.5 years and really was part of the initial development team. So there are a lot of personal points in this lecture that are things that either I've put together or that I've been part of developing. But a lot of things that we do, particularly as we start doing more and more complex work in the endovascular lab, really affect our longevity. You know, in terms of, for example, developing cataracts, our positioning, we're usually hunched over. I've been working with short people my entire life, and my neck has taken a beating. I sometimes get a little zinging out to my fingers. And so, you know, there are definitely elements that we'd like to change in terms of our ergonomics and how we work. But also there are, obviously, radiation is a big part of our work, and we're exposed to it every day. And for the IR and cardiac guys who are here, that's something that you're going to be exposed to, obviously, as well. And we're concerned about that. I mean, we had one of our largest or most prominent vascular people in the country, in the world, Roy Greenberg, who died just this past year from a intestinal cancer. And you know, although he may have had it from something else, definitely it's in the back of our mind, and we are you know, definitely concerned about how we do our work. If you look at, this is a study back from 2009, just looking at skin injuries from radiation. As the complexity of the case goes up, so does the risk of skin injury, and as you see here, also for fatal cancer risk. And so, you know, obviously when we spend multiple hours sometimes on very, very challenging cases, this is at the forefront of our concerns. As far as the Magellan robotic system, which is what we're primarily talking about today, it's been around, approved since 2012, and we've had it at our facility since September 2012. It's indicated for navigation in the peripheral vasculature, and so that really doesn't limit it to anything. You can use it in the venous system, the arterial system, any portion of either. And so, you know, it really makes it a very versatile catheter. Just to look at the main, I don't know if there's a pointer here. Yeah, here we go. Is this a pointer? Yeah. So there are different components. This large component right here is called the RCM, which is the Remote Catheter Manipulator. For those of you who are familiar with Intuitive Surgical and the Da Vinci robot, these components actually look very much like some of the cartridges you put into the Da Vinci robot, and that's because they were invented by the same people. So the people who invented the Da Vinci robot then moved over and invented this robot. Actually, this catheter system was invented in that gentleman's garage. The second component back here is the remote wire manipulator. For those of you who are involved in endovascular procedures, you know that we use different things to manipulate guide wires. We have many also different types of guide wires. We use torque devices, or we use our fingers, or we use maybe a little 4x4 to hold the wire, depending on what wire we use. But this will do the job of that, and you can do that remotely. Then you go to the console, the main console, and that's set up so you have one flat panel monitor in the middle. You have the 3D joystick right here. I don't use that, and I'll talk briefly on why I don't use it. And then you have the main controller here and a foot pedal. The foot pedal allows you to shift between the two catheters. They're telescoping between each other so that the controls will lock off on one and lock onto the other. The way, this is actually my own setup here and the way we devised it. You work with two hands, and on one hand here is all the guide wire touches are on this side, and all the catheter controls are on this side. Currently there are two approved catheters. This second one is the most recently approved catheter. You can see February 2014. I have not personally used this one outside of the lab, but this is the catheter I primarily use. I've currently done about 60 clinical cases, and I'll show you the variety of cases we've done. As I mentioned, it's been approved since May 2012. We had our system installed in September 2012. But essentially, it's a telescoping two-catheter system. So you have a sheath here, and then what we call a leader, or the catheter that's out here. They can be controlled independent of each other, and essentially there are target procedures, but as you'll see as we go through the cases, we use it for a lot more as far as the variety of cases. Now, if we go over to the main system that I've been using, essentially the sheath is a 9 French outer diameter. That may not be much to the medical students, but I'd say it's on the relatively big side. What's important to us when we talk about French size is the ability to do everything percutaneously. Obviously, the larger the sheath, the less likely we are to do it percutaneously. Although we do obviously bend the indications a little bit, and we do use some percutaneous devices and closure devices to close the arteriotomies or the puncture sites. But nevertheless, it's on the verge of not being able to close it with the closure devices that exist on the market as far as the indications. The outer diameter of the leader is 6 French, which means that for therapeutic devices that we have to pass through this sheath, they all have to be 6 French or below. Through the leader, you can pass a guide wire, and it accommodates essentially every guide wire from 014 to 035. I primarily have used 018 and 035 guide wires. The advantage of using a smaller guide wire is that you can actually inject contrast. If you use an 035 wire, you have to pull out the wire in order to inject contrast because it occupies almost the entire lumen. The lumen is 0.38 and the wire is 0.35. If you then go to the 6 French system, it has 2 different types of bend. You have a proximal bend and a distal bend, as you see right here. And you don't get the same types of bends and control as you do on the larger system, but again, compatible with the same guide wires. What I didn't mention is actually you have 6 degrees of freedom with both systems. This is kind of the way it looks. You would sit at the console, and you have the X-ray at your controls. This is a bedside control you saw just over there. It's basically the same thing as you have at the main console. The guide wire is manipulated remotely, as I mentioned, here on your left-hand side. And again, you can rotate that just like you would normally with your hands or a torque device. And then you can use a 3D joystick, or you can use this, these controls, touch controls, which is what I use exclusively. And you can see how precisely you can actually control. Now, of course, this is not what our vessels look like, but that would be nice if it were the case. Nevertheless, you can control this in those 6 degrees of freedom as I indicated. And if you go and you look at some of the benchtop work that was done before we started using this clinically, this is basically some in vitro data coming out of London. Some of our colleagues, vascular surgeons primarily over at the St. Mary's Hospital in London. And essentially what they showed was that fellows, or sorry, novices, were able to use the robotic system as efficiently or more efficiently than experienced people were able to use manual techniques. That in of itself on a silicone model I think has not great value, because really one of the limitations of any endovascular work is being able to understand how catheters and wires behave in diseased vessels. And diseased vessels will behave differently. You'd like to be able to appreciate on the monitor that your wire is doing something you don't want it to do, or your catheter is doing something you don't want it to do, for example, buckling or pushing back in some way. And so really, I think you know, it's important to look at it in a little bit of a different way, which is kind of what we did here. We used electromagnetic sensors to look at what we considered non-competent, which is almost everybody except for a couple of Hansen users, so engineers, myself and one other person, who were the experienced people. And what we see is that what this means, average sub-movement, is within each movement there are multiple sub-movements. Those actually designate whether you are moving this catheter or even a manual catheter. We've done this with manual catheters as well, whether you're moving that catheter efficiently or not. And efficiency is a sign of proficiency. And if you come down and you look at, I think one of the most interesting things here is this is what we call a posterior branch, or a third order branch in the case of the model we were using. And this really points out how I think a novice user or non-competent user is significantly worse than a competent user as the difficulty of the catheterization goes up. This is work we did back in 2010, 2011, part of the approval work for the robotic system. And this is the GLP study. These are all animals that I performed. So we had 11 animals, which we did in a lab up in Boston. And we essentially cannulated the aorta, contralateral iliofemoral artery, bilateral renal arteries, and SMA. And one of the things we wanted to see was tissue injury. That was very important, obviously, to the FDA, and obviously important to us as well. And so we wanted to evaluate the acute, subacute, chronic safety of vessel cannulation. So animals were sacrificed at different times. And the study endpoint was safe cannulation of the abdominal aortic branches and contralateral iliofemoral artery. When the animals were sacrificed, the pathology was essentially consisted of slices of the vessels, 2 to 3 milliliters apart, and the arteries were then assessed for disruption. And I don't really have to point it out, but if you look at the manual catheterization versus the robotic catheterization, now what I will say, and is not in the document, is that a lot of this catheterization work I did with a robot is actually wire-free. And despite that, still significantly less injury. There were no major injuries, and obviously a lot less minor injuries as well. This is essentially how the vessels were sectioned in order to look at primarily the areas we were concerned about were bifurcation points or orificial injuries. And if you look at specific vessels, so control being the manual catheterization versus test, which is the robotic catheterization, very few injuries. The main injuries were in the iliac artery. And if you broke that down into what kind of the severity of the injury, the higher the number, the worse the type of injury. And again, these were primarily iliac artery lesions, mild, mostly on the test, and then level 2 injuries on the control. But otherwise, overall, very few injuries that we experienced in these normal animals. If you go then to the first in man, which is kind of the next step of what we did, the primary endpoint here was successful cannulation of the target vessel. So we went for what we thought was probably the easiest and safest thing to do. We did this in Slovenia in Eastern Europe, beautiful country, by the way. And our primary endpoints were actually just being able to navigate to the lesion. And then our secondary endpoints were as such: insertion of guide wire into the target vessel, selective angiography of the target vessel, delivery of an angioplasty balloon or a stent through the sheath. So that's that 9 French sheath we were talking about. Safety of access at the insertion site. So we basically we did ultrasound evaluations for hematoma or pseudoaneurysms. And then assessing us, the physicians. We were 3 physicians treating these patients. We essentially had 20 patients treated, or 20 limbs treated rather. And this was the average age, weight, and primarily male patients. The lesions were 12 iliac lesions, SFA 24, and 5 popliteal lesions. These are the type of lesions. So in blue for the iliac segment, relatively benign lesions, and then in the FemPop segment, primarily TAS B. So also on the lower end of the disease. The tortuosity of the iliac tree was important for us to know because we had to navigate up and over the bifurcation. And again, most of those were mild disease. The primary endpoint in all patients was achieved, and all lesions were treated successfully except for 1. And if you look at the 3 users here, the 4th user actually only did 1 case, so I won't really talk about him. That was my partner, Alan Lumsden. This is actually myself over here. This is actually a cardiac surgeon who had never done an endovascular procedure in his life. And then, and this was an interventional radiologist right here. And what you do notice is there's much more navigation time for the cardiac surgeon. I'm not surprised. He was the only one that actually failed on recanalization of one of the SFA lesions. His fluoroscopy time was also higher, as was his total dose. And then I think that's significant. It's a significant take-home message because you can do the case doesn't mean you're really saving on radiation and that you're really saving on procedure time or obviously the total dose of the fluoroscopy. This is actually a partner of mine who helped us get into the robotics initially. He's a EP cardiologist. And he actually started using what's called the Sensei system, which is a larger 14 French system, when it first came out. And he started doing his procedures and really got very frustrated around case 21. He had a few perforations. It was taking him forever to do the cases. And then all of a sudden, he had a drop in his usage of radiation, his usage of contrast, and so on, and his procedure time specifically. And it's down to now he's actually doing cases with 5 minutes of radiation. And these are obviously long. For those of you who aren't familiar with EP cases, they can be quite tedious and long. And he says he doesn't even know how to do a case without the robot at this point. This is from a few years ago. But he really got us into the robotics. And I'll show some of the cases that we did with him in the beginning. But essentially worldwide, hundreds of successful cases have been done. I'll show some of those cases and kind of how it's broken up across the world. And then we really want to emphasize that it is a multidisciplinary platform of interventionalists that are doing these procedures, from vascular surgeons to IR and interventional cardiologists. We have about 25 plus, probably a little bit more at this point, physicians that are involved in these cases. And these I've underlined here are really the cases that we've done at Methodist using the robot. So a pretty good variety of cases. Worldwide, we've had 6 conversions to robotic navigation from manual. Those are all in Houston. And I'll say that's primarily because we don't necessarily plan our cases out for the robot. We go into a case and oftentimes start with our manual navigation. And when we fail that, we can convert to a robotic catheter, which doesn't take more than 10 minutes to convert over that. Well, there have been 12 conversions worldwide from robotic navigation to manual navigation, and some of those that are in Houston, I can explain those. But what determines the success and failure with the robotic system? There are, it's a fine line of how you draw a failure. A lot of it here early on is people kind of being nervous, and I understand that. That's totally understandable. You don't want to create any injuries, and we definitely don't want any. For those of us who have started these programs, you're watched carefully from your hospital and your competing physicians. They would like nothing more than you to fail in some programs. And a lot of programs, guys I know in France have had the same issues. And so you really want to be successful. So the impetus to cancel or stop a case robotics and even fail manually is okay, as long as they don't have kind of the evil eye giving you some trouble. As far as these manual to robotic cases, these are basically a variety of cases: lower extremity CTO, brachiocephalic veins. I've been using it quite a bit in veins for particularly dialysis patients where we're trying to recanalize central venous structures to either salvage a dialysis access, or for somebody who currently has no dialysis access and no good options and we want to create one for them. We've used, obviously, for lower extremity distal femoral artery. Here again, a variety of visceral, superior mesenteric artery. We've had a number of those, actually. And then robotics of manual conversions, I can tell you, at least for mine, this was a vena cava, which I wasn't able to, actually I have the case here to show you, I wasn't able to cross into the innominate vein. And primarily that's really an imaging issue. Unlike arteries where you have some guide in terms of looking at calcifications or some disease to give you an idea of where the vein is or where the vessel is, in veins it's not always the case. So veins, when they occlude, they become sclerotic, and unless you have some good techniques to look at, we've been starting now to use delayed MR imaging to identify the course of the vein, and that has helped us out some. But it's definitely not perfect yet. And so those are primarily the reasons I failed on venous recanalizations. I had some trouble initially with up and over very, very diseased vessels. And I solved that by by placing a 9 French sheath, a short 9 French sheath. That gives me that support at the groin that I don't get sometimes with just what we call bareback, and it's going in just with the robotic catheter and sheath. And then these over here were actually from our colleagues in France, and we kind of reviewed their cases with them here last November. And these were actually them being anxious about causing a complication and aborting early on the robotic navigation. If you look at kind of the spread of the areas where we're treating with the robot currently, aortofemoral seems to dominate. EVAR or endoleak, FEVAR, for those of you who don't know what that is, that's fenestrated EVAR. So basically for thoracoabdominal aneurysms, these are fenestrated stent grafts. We use it for the viscerals, the renals as well, upper extremity, thoracic, and those are primarily the venous cases I was mentioning. And then fenestrated TEVAR, that hasn't been something we've used it for, but I know they've used that at St. Mary's in London and also in Germany. And then some few uterine fibroid embolizations. One of the things that we've been working on now for about a year is ROVER, the Robotic Vascular and Endovascular Registry. The idea was to get a registry going where people would essentially place all their cases in. We'd be able to generate some real-life data. So the goal was to conduct a prospective, ongoing post-market surveillance of the device performance. And I don't know if these are community-based. I mean, most of the hospitals that have this system right now are actually tertiary referral centers primarily. And so, I think, I don't know if you're getting exactly what would be happening in a community setting, but it's going to give us a good idea of what exactly the failure patterns are, the kinds of lesions we're treating, and so on. And essentially, it's to serve as a database for the preparation of educational materials, abstracts, and so on. I think that's one of the things people really want now is to get some clinical data. We haven't really had any good clinical data outside of the first-in-man. Each place that buys the robot, we actually ask to be involved in the rover. And so the protocol has to be approved by the IRB at each hospital. And our goal was to enroll 500 subjects by the close of 2014. I think we're almost there already. Some of them will be retrospective. So for those of us who didn't get the IRB approval before we started, which is we're one of those hospitals. It took us about 8 months to get IRB approval, and so we'd already been doing quite a few cases. So I think 30 of our cases are retrospective, and then the rest is going to be prospective. As I mentioned, all installed sites are invited to participate. Our first publication should be coming out in October or so, and that's going to be primarily a collaboration between myself and Dr. Barry Katzen, who's an interventional radiologist down in Miami. And then we'll collect data for the next 5 years for analysis. Again, this is our experience in Houston, so the carotids have been done primarily by myself. Done quite a few visceral and renal segments. Some of those are obviously in association with aortic procedures for either fenestrations or sandwich, snorkel, all those fancy terms that we use for getting around having the appropriate fenestrated devices for thoracoabdominal aneurysms. And we've used it for some tibial lesions. That basically just means getting support all the way down to the popliteal artery. And then, of course, some aortic cases. And venous, again, has primarily been myself and one of my other partners. I'm going to go through some cases. This may be where I ask some of the medical students some questions. This is the first case we actually did. This is my partner, Alan Lumsden, who did this. We have a fairly active pulmonary transplant program, lung transplant program. And so we see quite a few anastomotic stenoses. This was a first case where Dr. Lumsden actually tried to get through the anastomotic stenosis and couldn't do so manually, at least with the support that he needed. And so he actually used the EP system, which is a Sensei system, has a 14 French catheter and sheath, or sheath rather, which he could get out and then treat the lesion appropriately. And he published that back a few years ago. I guess that's 2010. And that was actually Miguel Valderrabano, who's the the EP cardiologist that we've been working with. What this is actually called Navix. Navix is an EM navigation system, which they use for EP. And this is actually one of my patients that I did with Miguel as well. And the idea was really here to recanalize a dialysis patient's brachiocephalic vein on the right side in order to maintain the access he had on that arm. And so, one of the important things, as I mentioned earlier, is actually understanding where you are in the venous system. It's much harder than it actually is in the arterial system. At least I feel that way. So we used the Navix to kind of guide our path and draw out where we were aiming to go. And this is kind of after we had passed our device through. This is actually the case here. There was an existing Viabon stent in the brachiocephalic, which we needed to engage. Now, what you may be able to see here is, and probably you'll see it better once I show you the live cases, is that the flexibility of the Sensei system is very limited compared to the Magellan, which is the vascular system. Nevertheless, here you can see we can get through the Viabon stent and then eventually join up the dots and be able to treat the lesion appropriately. But really, we had tried already by manual catheterization to do this, could not get through, and really the patient didn't have many options, and so we opted to try and do this. And we did so successfully a few times actually with the Sensei system. and have since then done so successfully also with the Magellan system. This is the venous case I was telling you about. One of the problems is you think there's a short segment occlusion, which there is, but being able to actually identify that and get across it where it is exactly, this is actually not, it looks like it should be the innominate vein, but it's not. The innominate vein per the MR is somewhere down here, and we were never able to get across here. Essentially, for me, it's a limitation in terms of the imaging. Now that we're actually starting to figure that out and turn some delayed MR imaging, we're able to be a lot more successful in crossing these chronically occluded veins. So this is actually a patient that came to me with an abdominal mass right up around here, around his celiac artery. This, as you can see, is his aorta. And he actually spontaneously thrombosed his, or nearly thrombosed his right renal and thrombosed his left renal. We go on to find out later on when I actually end up operating on him, it was an aortic sarcoma, which he ended up actually passing from. But the point of this case is actually to, this is one of the first cases I did clinically here in Houston. And what I did was actually, since I had to treat both renals, I decided to do one side manually and one side robotically. And here we are, you can see the tip of the robotic system up here. And what we do is we use our CT scan. We do a non-contrast spin of the patient. You essentially do, you take it's a robotic C-arm. For us, we use Siemens, but most companies have a similar setup, whether it's Philips, and I know you have Philips here, and it's capable of doing, of course, all the same things. And we marry it to our preoperative CAT scan or MRI. It's basically an overlay. You overlay the MR or CT on top of your spin here. And then you can actually use, we've gone over to not using an entire 3D volume in order to look at our vasculature. I found it very confusing, and you weren't able to see the tools you were using. So we've gone over just using these fiducial markers. And you can actually see the leader right here. It's going up here north a little bit, and then the sheath down here. And so here you can see I've actually already flexed the leader into the renal artery, and you can see the wire going out here. One of the nice things about doing this, one of the things we worry about when you put a wire out into the kidney is a parenchymal injury. So particularly with this wire, which is a glide wire, if it migrates out too far, you can actually get a bleed in the parenchyma of the kidney. In the robotic system, you actually don't need that much support because your support is afforded to you by your leader and your sheath. And you'll see that in just a second. So here, actually, I've taken the leader out, and I have the sheath here. I'm going to ask one of the medical students. Where are the medical students? Somebody put their hand up in the air. Guy in the orange right there, in the middle. Oh. What is this right here? Okay, very good. Why do you think, yeah, so I injected contrast in here. Why do you think you can't see the aorta? Why do I only see the vena cava?
Did you see contrast in the iliac vein?
No, I'm in the artery, right? Remember I was told I was started in the aorta, and I was going into the renal artery. Get some help from next door. The guy in the gray. So what did I say was wrong with the renal arteries? Right, right. So where do you think the sheath is? Probably just beyond the occlusion, right? So where's the contrast going? I see the gears working. Huh? Yeah, so it's gonna go and go into your venous system, right? So the way to actually see your orifice is actually to pull back the sheath. And what's nice about the robot is you pull it back, it's going to stay where you want it to stay. It's not gonna migrate. For those of us who do this every day, we know that you're going to be holding your sheath so that it doesn't keep on backing up on you every time you try and put a device through there. Here you can actually see here I'm putting actually an IVUS catheter. IVUS is intravascular ultrasound for those of you who don't know. And here the idea of doing this was just to be able to see what it was obviously thrombus, and I wanted to make sure I could see where it ended and started. Again, here now we can mark the orifice of our right renal artery, and then treat as we need to. Here I essentially stented this, and obviously had to pull back the sheath a little bit more in order to be able to stent the origin of the lesion. On the left side, I actually did this manually, and I can tell you I lost access 3 times. But I insisted on doing it this way just to see what the difference was for me. What it meant is actually obviously a lot more radiation and a lot more challenge. You can see when you try and get a little more rigid device up, and we're trying to get our device up through here, is what happens, it buckles north. Now this renal artery, in all fairness, is probably a little more challenged than the other one, which was pretty much at a right angle, and here you're kind of working against yourself. But kind of the lessons for me from this case were I could maintain the sheath position very easily with a robot. I didn't need deep wire positioning, which obviously I like because I don't have to, change wire to what we usually use, which is a Rosen wire. I'm less concerned about creating a parenchymal injury. I have ease of tracking devices out there, again, without the sheath backing up. My radiation time was significantly less for the right versus the left, so robot versus the manual. And in this case, the procedure time was also significantly shorter. This is a different case. This is actually a patient of one of my partners. So he had actually tried once already to get access to this SMA. This was a dialysis patient who got severe abdominal pain during dialysis. And there couldn't find any other explanation for it other than this high-grade stenosis of his SMA, which is right here. Sorry, a little bit lower down, right over there. And so he insisted on still trying a catheter. You can have a glide catheter here, a multi-purpose glide catheter here. You can see it's actually at the origin of the SMA, but he was never able to get a wire across. And part of that is support. He did try to put a sheath down, and still that did not help him in any way. Magged up here, you can see here's the robot. This is the only case I've ever done from an axillary access for the robot. Essentially here, if you saw, I flexed the robot. Here I'm advancing the wire. You have your leader here and your sheath here. Then I can bring my robotic catheter down. Again, that gives it quite a bit of support. And here is actually our fiducial markers. Tells us the trajectory of the vessel, and we essentially have the wire follow that path, eventually bringing down our sheath. And this, I can sit here and brag, but this really took us 3 minutes, and it was primarily the fellow doing it. So a real ego blow to my partner. And then eventually, as I mentioned there, you bring the sheath down, and then when you're ready to treat, you can back your sheath up and you don't lose your position. For what other things we use it for are SFA occlusions. You can see what normally happens when you do a case is this would be like a terminal branch or collateral. The wire wants to always take the path of least resistance, which is down there. What the robot allows you to do, and there are a lot of obviously different devices you can use to get through lesions, but it allows you to bend away. You can also go subintimal if you wanted to, but it allows you to bend away from that vessel that you're trying to stay away from, which is that terminal branch I mentioned. This is actually a case I did live for a meeting we had last December in Houston. And here you can see me at the console. And this essentially, it's an SFA occlusion, long length occlusion just beyond the origin of the SFA. And here we have our sheath and our leader coming down here. You can see here what I do, which is what we oftentimes do. You get a loop in your wire, and you're cutting or going subintimal until it pops into the vessel. And you'll see me here in a second bring down my leader. And of course, you're doing a live case, everybody's holding their breath because you hope you're not just going to keep dissecting the vessel all the way down and destroy your outflow. But this, obviously, since I'm showing it to you, was successful. But it was actually quite easy, and all the ones that I've done with the robot have been this way. And I don't know if it's just the support you're getting with the catheter and the sheath, but it has been a very easy way of doing these cases. Here's a different cases. Actually, I didn't do any of this. I just watched. This is the fellow doing it. So she trained really over a week before that, and this was her first case doing it clinically. So you can see on the aortogram, this is a patient with buttock claudication. Most patients actually tolerate just having one open internal iliac. You have occasional patients who, when they have an internal iliac that's occluded on one side, and we know that from aortic endografting, if we embolize one of the hypogastric arteries, sometimes they get pretty severe buttock claudication, despite having a wide open hypogastric on the opposite side. And so our goal here was really to try and treat this. We came up and over, and you can see she's done this all by herself, like a big girl, and done very well. This was really, I was surprised at how easily she was able to do this. She then stented this and luckily resolved the gentleman's buttock claudication. So I think in conclusion, the endovascular robotics have a huge potential. You can see kind of the variety of cases we've done, but I think it has potential for making our cases potentially more efficient. It has potential for reducing the amount of radiation we're exposed to, which is obviously extremely important. You know, we've found it to be a game changer in a lot of different cases that we do. One of my partners did the other day a splenic artery aneurysm, and as you may or may not know, some of the splenic artery aneurysms, when you go out to that splenic artery aneurysm, the splenic artery itself is very, very tortuous and can have multiple loops. And the device actually took all those loops without any hesitation whatsoever. There is a learning curve. This is not something where you go out and day one you're expected to be as good as the experts. And I don't really know what that number is. It's probably a little less than it is for EP, and that's kind of been our experience so far as observing the fellows. The lab is somewhat affected by the presence of the robot, but it doesn't have a huge presence. I don't think that should be a deterrent for not using the robot. Our TAVR program works in the same room as our robot, and they initially had a few choice words for the robot. We're not very happy with it, but over time it's something that's become part of our workflow, and so it really has not been a huge issue in our room. I think as worldwide centers continue to accrue more and more cases, I think we'll be able to provide a better idea of, one, the type of cases we do, the type of cases we fail on, and potentially some of the complications we're incurring along the way. I really think, and I said this early on, I think multi-specialty usage, particularly from even a financial standpoint, makes a lot of sense for the hospitals. We've been using this with our cardiologists and our neurointerventionalists primarily. And I think it's really paving the road for us for a lot better interactions and a lot more innovation on cases. Particularly neurointerventionalists bring a lot of different techniques to a procedure that we aren't necessarily, as vascular surgeons, very in tune with. I can speak for myself, so I've learned a ton from them, and they've learned a ton back from us. And I think that is really why it's kind of the way forward. I appreciate you listening. Thank you very much.
Any questions, comments for Dr. Bismuth?
I think it's an impressive.
Yes. Sorry.
Any question?
Yeah.
I've been interventional in a long time.
Yeah.
But I remember like doing 4 vessels, and you go up to selectively and put the catheter in the internal carotid.
Yeah.
And afterwards, when you're through, you take the catheter out, because sometimes it can be spasm. if you're using, and you can feel the resistance, how do you are you just pushing back and things are just causing a section because you don't feel that there's resistance?
No, so that's, you know, that's actually been a very common question. Is the reality is I don't really think, and the other guys who do interventions here can pipe in, but I don't feel that. Yeah, there's some things where you're actually feeling the wire. You're, you know, it's primarily when you're trying to get it through an occlusion, you can kind of feel how much you're pushing. For the most part, I think for me, it's really what you're seeing on the monitor that's telling you what you're messing up and what you're doing, right? I think the advantage of this, I've done carotids myself with a robot. One of the nice things is you don't have to, so one of the relative contraindications to doing a carotid stent is an external artery occlusion, right? So if the external carotid is occluded, you can't get your wire up safely without going through the lesion. In this case, you actually don't have to bury your wire up high because you don't need much purchase to get the robot up. The robot is doing most of the work. So you can actually leave your wire in the common carotid, never traverse the lesion, and still get your robot up. So you probably don't see as much of that spasm as you may if you have your wire buried up. Of course, then you can still have spasm from the protection device, neuroprotection device, right? But no, it's not something we've seen. I haven't seen any issues of that sort. But it's obviously a potential problem and something obviously you should think about. Yeah, for sure. Yep.
Excellent talk.
Thank you.
Thank you very much for sharing your experience with us. I do have some questions about this. Like you said, this is a great thing. It's kind of have a great potential for us, you know, vascular surgeons. But like a robotic, all the robotics have the same problems. How can you keep the patient hold still? And because that's can generate the potential, you know, problems. So if you cannot feel that, and the patient move, your machine is not going to move.
Correct.
So that can generate, you know, big issues.
So there's two ways. So one is obviously anesthesia is always good. And when we do our aortic cases, we always use anesthesia because we use our 3D overlay so much and we rely on it completely. We don't do any aortograms anymore at all for our aortic cases. I'll navigate into any visceral or any renal artery without doing an aortogram because I'm so confident in our 3D overlay. So I save on contrast and I save on, and the ability to keep the robot in position, you know, where you're not moving the sheath all the time, really allows me to get into that vessel much easier. The other thing you do, but you're right, if you have a patient who's awake and he moves, you'll lose your fiducial markers and you're kind of done from that standpoint, right? So we're actually looking right now, we're working on an EM sensor that's going to be part of the robotic system to update that information. And it'll be integrated with your 3D imaging system so that you can then update your fiducial markers. Because, I mean, that's obviously a problem. And I think we'd like to be able to do a lot more of these procedures without general anesthesia.
Yeah. Okay. Another question is, this system basically just mainly used for navigation and cross lesions, but you know, as the endovascular procedures, we still have a lot of things to do.
Correct.
You balloon it, you stand, you cannulate, you do fenestration. All the other jobs you have still need to go in to do it by yourself.
Right. So the limitation is, I would say, is your 6 French inner diameter on the sheath, which is your platform for treating, right? If you're just treating a single renal or a single SMA or whatever, that the sheath is my treatment platform. If you're doing a fenestrated endograft or you're doing a snorkel or a periscope, whatever it is you're doing, and oftentimes we're doing 2 vessels or 3 or 4 vessels. And so when you're cannulating the vessels, you'd like to be able to obviously, what we do is we leave a wire. We usually leave, for example, in the renals, we'll leave a Rosen wire out and then bring a regular sheath up, an Ansel, high flex Ansel sheath up, and leave that in place and then use the robot for the next vessel. So there are some exchanges, and they can actually be, until you're comfortable with it, they can be a little cumbersome. Because remember, if you look at the system, you have two catheters, so a leader, and you have the sheath, and you have the cartridges. All that weighs some, and so you obviously know if that falls down, it can easily pull the wire out. So there is a little bit of a workflow that you need to work with. But for a lot of things, what we do, if I'm treating the SFA, the 6 French sheath is enough, and I can treat most everything in the SFA.
So are you going to do a prospective randomized trial to compare the regular way, routine way we are currently working with this, to see any difference, your computations or your cross success rates or stuff like that?
So what we're doing is, so we are doing it for X-ray exposure. So we have a X-ray safety person who is with us now for the next year, who is monitoring similar types of cases. We look at who's doing the procedure, whether it's the attending or whether it's the fellow, what level of training they're at, and we see kind of what the differences are between the robot and the catheter, which obviously is important. In terms of complication rates, it's hard to do a randomized trial. I know the people in London are doing a randomized trial for their FEVARs. So what they're doing is they'll cannulate with one side, a little bit like I did, they cannulate one side with the robot and the other side with the catheter. But it's not true randomization, right? So, I don't know that you'll get a true randomized trial out of this.
Yeah, it's very difficult. You probably still have bias. If you believe this, you try a little bit and say, I give up, I go, turn to you. Yeah. This is very good. The thing is, we can sometimes, not sometimes, all the time, we have to deal with difficult, sub-branches, cannulation. We can use a pre-shipped guiding catheters and wires, but only this is very limited. You only have a certain angles kind of pre-shaped. But this thing, you can just, shape whichever angle you want, and maybe even 3D, shape, right? It's not like just a one direction angle. So I think
I can tell you, our partners in Germany actually had a FEVAR gone terribly wrong. Basically, the fenestrations were so far off, and they were going to convert to open, and they were able to navigate into the vessels, and they showed this as just they would never been able to do this.
Yeah. We do fenestration, suprarenal and thoracoabdominal FEVARs, and so I think this would definitely help us. So.
Yeah.
Does using this system have any effect in decreasing rates of restenosis? No, not at all.
No, I mean that's more kind of the therapeutic device, related to the therapeutic device, and there's no ideal therapeutic device on the market as far as I'm concerned.
The system gives us what we were doing 30 years ago, when we were actually shaping our own catheters. We were shaping our catheters outside the body. Now we basically shape these catheters inside the body, which gives us that extra comfort of doing it. I still have
I mean, we all do that a little bit, right?
Yeah, on that. So that is it's pretty much gone into our we can do it inside the body with a big.
No, it's actually a very hard thing to teach. Actually, even fellows, very hard thing to teach. That I think a lot of us is about seeing the anatomy, and unless we were talking earlier, for me is if they don't see the angiogram, they have a hard time telling you, well, I need this kind of bend on the catheter, I need this kind of bend on the wire. Exactly. Exactly. Yeah. Yeah.
Well, this is the first part.
How much would this increase the cost of the procedure for the patient?
Choke up a little bit there. No, so yeah, it does. It increases the cost a little bit, but actually, I did a financial analysis for the hospital because I need to do that to get the robot. And the reality is, it's marginal. So there's some cases, obviously, where you would lose a little bit more. The disposables cost about $2,500. But if you think about even a crosser device for an SFA occlusion, can easily cost over $1,000. So there is a little bit of an issue there, but for the most part, it's not a major issue. The initial cost is significant.
Undoubtedly, this is the way to go, and it will be the way to go in the future, robotics. Especially because of radiation. You're going to be saving some radiation. There's still a lot of things to be worked out. Interesting today is that you're not going to not only see this, there is outside the van with the robot for you to do simulation on vessels. It's a virtual exercise that really I invite all of us to go there and do it. I played a little bit this morning, and now is your time to play. And I think that all together, combined with vascular surgery and neurointerventional radiology, this is something very nice for us to work with and work more integrated. Yeah.
Can you tell us a little bit about the access site complication? So usually for SFA or renal or respiratory, we're doing 6-French platform unless you have the new system. But you're upgrading to a 9-French sheet.
So I've had 2 failures of percutaneous closure devices. Mostly I use your standard off-the-shelf closure devices and have no issues with it. I haven't personally had any pseudoaneurysms or large hematomas or anything of that sort, and I don't remember if any of my other partners have had, but it's not been in our user meeting this past June. There was actually no talk of any serious complications at the access site. Now, a lot of the cases are being done by open for some of the FEVARs and so on, particularly for the centers that are doing in Europe. For a lot of the peripheral stuff, it's primarily centers in the U.S. that are doing it, and none of them have really remarked on any serious complications.
So you go in without a sheet, but you just use the sheet from the robots?
Correct.
And you leave a wire, take it out, and then do a plug close?
Right, so usually what I do is I put a Benson wire up to start with. I put my system in over the Benson wire, leave that, hook up the catheter to the RCM that we were looking at in the beginning, and then I exchange for a glide wire. The reason you use a glide wire is the guide wire manipulator are these kind of silicone bands, and really the only thing that'll grab it really, or the only wire it'll grab properly, it'll be a glide wire. That tackiness that we have, that we always complain about with the glide wire, actually works to our advantage here. And then basically you navigate. And then at the end, yeah, I leave a wire. Most of my closures are actually star close for the most part, and then on some occasions we used a pre-close.
This case you showed here for the catheterization?
Yes. Yes.
That was a 035 wire?
That was an 035 wire, correct.
Have you ever any experience of being activated?
Yeah. Not with the robot, but you could. I mean, our room is not really set up to flip the patient around. If you have that set up, I think it'd probably be great. We just don't have that set up. Now that we're moving to the cath lab, maybe something we want to think about. Yeah, I mean that's probably a good option. Yes, sir.
Barish, just when you bring out your checkbook and lie, the radiology department, the cardiovascular, the surgery, we'll buy the 11 swine.
Right.
Not more than that.
Right. You just have to make the case for how this improves our research endeavors and translational research. So good. This is fantastic. Thank you so much.